Okay, so we have heard about from Emmanuel if we really need cartilage tissue engineering, and almost in 2009, Peltare, Wixmerton and Martin wrote a paper about the need of cartilage tissue engineering, and they asked the question, what is the quality of the delivered cells? They also talked about how to improve the matrix that we are using for the cells and what type of cytokines are we are to use. And then if we look upon an injury in the joint, what to expect? Well, we could look upon the joint as a joint incubator for tissue regeneration. You have a bleeding in an osteochondral defect. You have ingrowth of cells from the bone marrow. Some cells could even invade from the cartilage, some from the synovial lining, and there is also growth factors. But unfortunately, it's not enough. So we need cells. Well, we know that we could use the true committed chondrocytes, that's for sure, but more and more in the future we will use non-chondrocytes, chondrogenic cells for the repair. And we could use them most often as autologous chondrocytes, committed chondrocytes, or chondrogenic autologous progenitor cells, but also as allogenic cells. We use them free in suspension most often before. Now we are using most cells in scaffolds as immature graft, but maybe in the future we will also use fully developed mature grafts. If we look upon bone marrow stem cells, and we've heard it earlier today, most often we are using autologous bone marrow cells, and it's very uncommon to use allogenic stem cells, but there are reports that you could combine allogenic stem cells in order to increase the number of cells, especially in one-stage procedure, as we will hear more a little later in this talk. We could also stimulate the bone marrow to release so-called blood progenitor cells, and we could collect those blood progenitor cells, mix them, for example, with hyaluronic acid, and inject them in the joint at the same time that we do some sort of repair, like a microfracturing. And this group in Kuala Lumpur, So and co-workers, they have done a randomized study where they used this technology, and they could show with this growth factor stimulation that you will have a better morphology when you looked upon the MRI and when you looked upon the histology. But clinically, they didn't see any differences, but it was a very small number of patients included in this study. Well, there are also other non-chondrocyte chondrogenic cells that we could use. We will use more of synovial cells, and you know the synovial cells are really strong chondrogenic cells. We could use adipose cells, we could use umbilical cord cells, and actually also menstrual blood-derived MSCs have been reported to be used for chondrogenic purposes, and muscle-derived stem cells. For sure, still we are to use chondrocytes, and you know chondrocytes for implantation was first done in 1987, 34 years ago. And today we have 4 generations of ICI. The first generation was cells in suspension under periosteum roof. Then the second generation became cells in suspension under a collagen roof. But quite fast we moved into the third generation with cells grown in a matrix or on a matrix. And finally, today, we also have 4th generation of ICI, where you see cells used directly as one-stage procedures. The first generation of ICI, as you know, 34 years ago, it was the first operation. So we have long-term results. We know that this is a technology that could give good results. But we know also that the first generation of ICI was an open procedure. Your risk of loosening of cells because it's a cells in suspension, and you also have an uneven distribution, and that's why we went into the cell carriers and cell-seeded scaffolds. And if you look upon a cell carrier used today, one is the Macy, where the cells are grown on the surface of the material, and it's put into the joint with the cells facing the bone, and quite fast the cells leave the material and goes into the fibrin glow. And this is interesting because this is what you could see also with the new technology like minced cartilage. With this type of technology, you could also achieve good results with the third generation of ICI. And with the SUMMIT study, so far the largest cartilage repair study in the world with 144 patients, we could see that you could have significantly better results with the cell-seeded graft versus microfracturing at 2 years, at 3 years, and at 5 years. So it's sustained effect for the years. And also with the cell scaffold like hyalograph, you could have good results up till 7 years, as you could see here, long-term durability from 1 year to 7 years, sustained results. And it's interesting also to use this technology because, for example, myself, I'm using the hyalograph where I could fold the graft, I could put it into several layers, I could put it into transarthroscopic in about 90% of the cases. I could use it for tibial plateau lesions, for hip lesions, etc., etc. So it's easily handled. But there are also new technologies to be of interest to use with chondrocytes. It's a non-scaffold technology like the spherox, where you put several of these spheres into the area to get a resurfacing with these chondrocytes. And also it's of interest to know that even though we discussed that this is a new technology, as it has been available for more than 30 years, there are also randomized studies. And with the ICI technology, there are 20 randomized studies, 16 versus another technique. And 9 of these 16, you had ICI having significantly better result versus the other technique. And in 10 of these studies, it was against the so-called golden standard of microfracturing. And in 8 of those 10 studies, they had significantly better results in different parameters. So the cell technology is quite well studied. It's one of the most well-studied techniques actually in orthopedics. But then we went also to the 4th generation of ICI because, to make 2 operations, maybe you could do it faster, you could do it in different ways. And there are 2 ways you could go with the 4th generation of ICI. You could do it as one-stage procedure where you isolate the chondrocytes and mix it with, at the same time, autologous bone marrow cells, like in the INSTRUCT study. Or you could isolate chondrons, so to speak, chondrocytes with the surrounding pericellular matrix and combine it with allogenic matrix, like the IMPACT study. But also a 4th generation of ICI is minced cartilage as developed as the KAIS technology, where you fragment cartilage into small pieces, put it on a resorbable membrane and put it into the joint. It's more or less like the Macy techniques, but instead of cultured chondrocytes, you have minced cartilage. And there are 2 randomized studies, one American and one European, showing the same results, that you could get significantly better results in KOOS and IKDC with KAIS cartilage fragment versus microfracturing. It could also be developed into different ways, and you have the AutoCart technology also with fragment cartilage, where you mix it with micronized allogenic cartilage. You use also platelet-rich plasma, PRP, to get growth factor stimulation and fibrin glow, and put it into a biological porridge into the joint in order to start the chondrogenic effect. Our lab in Gothenburg have been interesting to look about the minced cartilage, and we could see quite nicely how there is an outgrowth from the fragment. So you could see that you could produce cartilage from the minced fragment, and they could fuse and start to produce a cartilaginous tissue. And that's why I'm interested to use also the fragment. And And the way that I'm using it is called CAFRIMA, cartilage fragment implantation membrane augmented technique. You debride the lesion, you put fibrin glue into the defect area, and then you use the Artrex graft collector to collect minced cartilage, and you get very dense amount of fragment cartilage. And this fragment cartilage, you could put it into a syringe, you inject it directly into the fibrin glue, and you cover it with an hyaluronic acid membrane like the Hyalofast. So this is one way to have a one-stage ICI generation 4. You could also use it as an allogenic fragment, a micronized matrix off the shelf. But it's not only autologous chondrocytes that will be of interest in the future. There are already clinical use of nasal chondrocytes, and maybe we will also use auricular and coastal chondrocytes. Allograft chondrocytes have been used and could be used also in the future, maybe mixed with allogenic MSCs. Synogenic chondrocytes, more difficult, but maybe, and also iPS and embryonic cells. So here on this picture, you see the ideal repair to the left. To the right, you see an ICI implantation in a rabbit knee, and the low picture is a biopsy from a human being. You could get quite nice articular cartilage, hyaline-like cartilage, but it's not a full generation. So how to be further improved? Well, we will see more of a combined treatment where you use 3D printing, and with a biopen in bioink, you could directly print the cells into the defect area. And you then print bone marrow cells into the bottom of the defect, and then you have the chondrocytes or the chondrogenic cells in different layers. And you could also choose exactly how you make your layers, and you will have what we call a gradient repair. So I think this will be in the future, a 3D printing directly into the joint. And this is what we are working a little on in the lab in Gothenburg. Finally, talking about algorithm. If you look upon the knee joint, you could see that 1 centimeter is quite a large defect compared to the size of the condyle. And 2 centimeters, 3 centimeters, it's huge defects. And I don't believe it's not good to use bone marrow stimulation alone for a 1 centimeter defect. So I rerouted my way to use the repair. So BMS alone are for small defects around 5 millimeters. Augmented bone marrow stimulation, like bone marrow stimulation plus we heard before, is up to 2 centimeters. 2 centimeter larger cell-based, it could be chondrocytes, it could be minced fragments, etc. Allografts for very large defects. But also the more complicated technologies like ICI, AMIC, etc. could be used when for smaller defects, if those smaller defects have been treated with some other technique before and had failed. So finally, if we look upon the cells to use for the future, there are studies to show that the committed chondrocytes, they outperform mesenchymal stem cells. It's important to remember in chondrogenic effect. Young chondrocytes are certainly better than old chondrocytes, and cartilage tissue progenitor cells, so-called chondrocytes of stem cells characteristics in cartilage, that outperform the normal so-called committed chondrocytes. Important to remember for the future. So finally, there is no one and only technique even in the future for cartilage repair. One has to adjust to the varying clinical situation and from single to combined hybrid methods. And we look upon the joint, we have to look upon the BMI, we have to look upon the alignment, we have to look upon if the patient have been meniscectomized, if there is an osteochondral defect, if there's a chondral defect, etc., etc. And then we know that we could more directly find the right treatment for small lesions, for large lesions, for chondral and osteochondral lesion. We look upon the age, maybe we give some growth factors. If it's a pre-OA, we could treat it. If it's an early OA, maybe we could halt the process into full OA. So this is the way that we use our tools for a biological joint preservation. And with this restored joint homeostasis, a cartilage repair will achieve best success. So we restore joint incongruity, defect areas with as good as possible, good quality cartilage repair, which will give us long-term durability with less risk for the further deterioration of the joint and its function. And I finally thank you very much for your attention.